Hi, so my name is Brian Johnston. I'm an anaesthetist and intensive care clinician based in Liverpool in the United Kingdom. I'm also a doctoral research fellow, and my role within Target is within Work Package 8. So that's looking at the um, clinical studies and the clinical implementation of the Target project. Atrial fibrillation, it's the most common arrhythmia worldwide, but it's a particular challenge in acutely unwell patients for a number of reasons. Um, Most of the guidelines that exist for atrial fibrillation are derived from patients that have atrial fibrillation long term or develop it not in an acute period. So actually, a lot of the research isn't applicable to patients that develop it during acute illness. So the etiology behind atrial fibrillation is slightly different. The triggers for the atrial fibrillation developing is slightly different. So whereas patients that have chronic atrial fibrillation, there are very well-known risk factors such as hypertension, coronary artery disease, and so on. That may not exist in those patients that develop it acutely. So the etiology is probably slightly different. The triggers are slightly different. Um, it's also a very serious condition during acute illness. So there are a lot of negative outcomes for patients that develop this condition, particularly acutely, so in the short term, but also in the long term. So in the short term, they become more hemodynamically unstable. It's more difficult to control their blood pressure when they develop atrial fibrillation. And in the long term, we know that there's probably a link between developing atrial fibrillation during acute illness and subsequently having episodes of it, even after your acute illness. So, potentially months to years after you've recovered from your acute illness. One of the mainstays of treatment for atrial fibrillation is anticoagulation, but this presents quite a particular challenge during acute illness because quite often those patients have other risk factors that may stop us from being able to anticoagulate them. So a typical example would be your surgical patient. We wouldn't typically want to start anticoagulation for atrial fibrillation if they've just had major surgery, for example. So the actual treatments that are well proven to prevent complications are slightly more difficult to administer in the acute setting. We also know that our treatment for atrial fibrillation, a lot of our guidelines, as I say, were derived from patients with chronic AF. And it's uncertain how applicable those guidelines are, in particular those treatments are in the acute setting. So we really have limited evidence to go on with the management of AF. And like I said, leading on to long-term consequences of AF, we know that patients that develop AF during an acute illness are more likely to develop AF subsequently, even after their acute illness. So they really present challenges at all aspects of their journey, I suppose, from the acute setting, the short-term impact, and even after acute illness, they still present a challenge to treat. So research, as I say, research into atrial fibrillation in the acute setting is probably behind research into atrial fibrillation management overall. There are a number of areas that are very exciting areas at the moment, looking at the management of atrial fibrillation. So one is looking at, can we predict those patients that will develop AF? So if we take a typical example, sepsis, for instance, we know that a significant number of patients that suffer from sepsis or an acute infection will develop atrial fibrillation, but not all of them. So trying to determine those patients that are at risk of developing AF is a huge area of interest for clinicians. Looking at if we can detect particular markers in the ECG, so the electrical tracing of the heart, or are there particular markers within the blood, looking at particular biomarkers or physiomarkers, is a huge area of research. And the reason for that is twofold. If we can predict those patients, we have some warning of it. But if we can predict those patients that will develop AF, can we actually treat it before it starts? So can we prevent it? So there's a huge area of interest in prediction prevention and looking for particular subgroups or individuals that are more at risk. As I mentioned, anticoagulation is a mainstay of atrial fibrillation treatment. So likewise, trying to determine those patients that are at increased risks of developing blood clots as part of their atrial fibrillation, but also those groups that we can or cannot anticoagulate for the condition itself. One of the most commonly used prediction tools, the CHA2DS2-VASc score, for atrial fibrillation and determining whether or not you should start anticoagulation to prevent strokes and other complications, may not be directly applicable to patients during acute illness. So really trying to predict those patients and determine which patients will derive benefit is a huge area of research. And then likewise, I've already mentioned patients that develop atrial fibrillation during an acute illness are much more likely to develop it long term. So there's a huge area of interest looking at trying to predict those patients, trying to define those patients, trying to detect those patients. And that has sort of huge consequences, not only for the patient themselves, but for healthcare systems going forward. If we can predict which patients will need ongoing care, long-term follow-up for their atrial fibrillation, we can potentially prevent devastating impacts such as stroke later on. Artificial intelligence is really going to hopefully revolutionize atrial fibrillation research, particularly in the critical care setting. So if within critical care we generate a huge amount of data from patients, and doctors are, critical care doctors are used to integrating all of that and deciding what is the best treatment for their patients. But the sheer size of data, it's almost impossible for a human to integrate all aspects. So a typical patient coming into critical care will have blood results, they will have continuous monitoring of heart rate, respiratory rate, blood pressure, ECG. They will have imaging data, so x-rays, CT scans, so huge amounts of data. AI really gives us an opportunity to try and integrate all of that data and address some of those research challenges. So we could hopefully get to a point where we're integrating data in a real-time process, looking at trying to predict those patients. So as they come through the door of critical care, integrating the data that's been derived from the stay in A&E or the acute medical ward, bringing it all together, looking at their ECG data, their hemodynamic data, their biomarkers. Can we predict those patients during their acute stay that will develop AF? And like I said, can we then preemptively treat that condition? Right the way through to, can we risk stratify those patients that need anticoagulation or further treatment? And it's not about replacing doctors, it's about giving them a support tool to guide their treatment and their strategies. One other area that I think AI could particularly make a difference is looking at continuous monitoring and automated warnings. So, like I said, there's huge amounts of data that are generated for these patients. It's impossible for a human to assimilate all of that data and continuously, review all of that data 24 hours a day. So there is a potential for missing critical incidents, like a period of atrial fibrillation, particularly if they're short episodes of atrial fibrillation, particularly throughout the day, for example. So AI could really assist us in developing automated systems that may be able to do that better. So it may be able to detect short periods of atrial fibrillation, it may be able to detect short multiple periods that maybe a human would pick up on. So AI hopefully will be a good tool for clinicians going forward. So digital twins is essentially where the fun stuff really starts to happen with all of this data and artificial intelligence data that we generate. So a digital twin for a simple way of describing it, is effectively taking all of that data that I've mentioned. So the past medical history, the demographic data, the data when the patient presents to hospital, so their blood results, their ECG, their physiological markers, and integrating it to develop a real-time model of that individual. And that's when we can really start to personalize AF prediction, AF treatment, and AF management. So digital twins could really revolutionize how we approach AF. Clinicians could potentially have a digital twin that they can try out different treatments on before administering them to the patient to see whether or not that treatment is the best course of action. Likewise, we've mentioned anticoagulation. So we could, in real time, use a digital twin to model the risk-benefit of giving anticoagulation. Is it going to benefit the patient by preventing blood clots if they have a stroke, for example, or is it going to increase their risk of bleeding events? And then even after the acute phase, into the longer term stay of the patient, if we're integrating significant amounts of data, we can potentially use that to predict which patients we need to follow up long term. So streamlining the process, do we need to follow up certain patients into the community? Do we need to anticoagulate them in the community? And so on. So it's really about developing an AI-enhanced decision support tool without causing any harm to the patient. So Target is effectively the fruition of what I've just mentioned. So artificial intelligence and how it can help clinicians and research, developing digital twins. And Target's bringing a huge consortium of experts in the field of cardiology, atrial fibrillation, stroke management, stroke rehabilitation, artificial intelligence, machine learning. So there's a huge amount of expertise and experience in that field. What Target I can see leading to is all of the things I've mentioned so far. So personalized diagnosis, personalized risk prediction of patients coming in, potentially early warning scores, looking at subgroups of patients who we know will develop atrial fibrillation or who will become more unwell, looking at whether or not those patients need to have anticoagulation, and then right the way through to developing the digital twin for each of those individuals. So again, that has huge implications for the treatment strategies that we use. One of the ongoing debates within the atrial fibrillation world is whether we want to control the rate of the atrial fibrillation or whether we want to control the rhythm. And there are certain nuances to that. I think we're probably still uncertain as to what the best strategy is acutely, but I can see a situation where Target having derived a digital twin for an individual could be really powerful in helping answer these questions. At the same time, we have the opportunity to develop significant or generate significant amounts of data that we can analyze. So we have the potential to look at all of that physiological data, all of that biological data, and try and really answer some of those research questions that are still outstanding. Also, we have the opportunity to really drill down into what is the best treatment, and on a personalized level, which patients need certain types of drugs. To give you an example, in critical care, we may have a number of drugs that can interact with drugs that we would treat for atrial fibrillation with, for example. So if we're generating all of this data, we have the real opportunity to try and tease out those nuances effectively of which drugs are best targeted for each individual. And again, Target has a huge role in the long-term management of these conditions and in the side effects of atrial fibrillation. So one of the big risk factors, or one of the big negative consequences of atrial fibrillation, stroke. Target will really help revolutionize our understanding of stroke during acute illness and during atrial fibrillation during acute illness, sorry, and help us guide our anticoagulation strategies. I suppose it's just to bring everything together. Watch this space. Target is a very exciting project. I'm slightly biased, but I think it's going to revolutionize our understanding of atrial fibrillation during acute illness and stroke during acute illness, and how we can better detect that, how we can use artificial intelligence to really develop precision models and individualized care for our patients, how we can improve our anticoagulation and stroke prevention strategies, and how we can improve our long-term monitoring of these patients. It's very easy for us to get wrapped up in the exciting world of digital twins, artificial intelligence, and so on. But at the end of this, there is a patient. So I think all of the clinicians in Target have that at the forefront of their mind. Actually, all of these tools are trying to really derive benefit for our patients and try to improve their outcome long term.